Hello everyone, it's Dr. Locklear here, and I'm coming to you with chapter 25 in your McKinney maternity book, and we're talking about pregnancy-related complications. This chapter is fairly lengthy, so I'm going to try to keep it as short as I can and maybe possibly direct you to some things that you need to read as you go through this chapter. Here are your objectives. We're going to look at hemorrhagic conditions of early pregnancy, spontaneous abortion, ectopic pregnancy, gestational trophoblastic disease. We're going to talk about disorders that affect the placenta. We're going to look at the effects and management of hyperemesis gravidarum or morning sickness, describe the development and management of hypertensive disorders or preeclampsia, or pregnancy-induced hypertension is another term for it. We're going to talk about the RH and ABO incompatibility, which relates to the RH factor of your blood. So you're either negative or you're positive, and how that affects the fetus. So let's get started. So one of the first things that we're going to look at is spontaneous abortion, and this starts on page 525. The three most common causes of hemorrhage during the first half of pregnancy are abortion, ectopic pregnancy, and gestational trophoblastic disease, including hydidiform mole. So what is an abortion? It is the loss of pregnancy before the fetus is viable, that is, before it is capable of living outside the uterus. The medical consensus today is that a fetus of less than 20 weeks of gestation or weighing less than 500 grams is not viable. Abortion may either be spontaneous or induced. Spontaneous abortion denotes termination of a pregnancy without action taken by the woman or any other person. So it's spontaneous. It happens on its own. A miscarriage is a term used by lay people to denote an abortion that has occurred spontaneously as opposed to one that has been induced, and the term is becoming more accepted by professionals as well. Elective termination of pregnancy is called induced abortion and will be discussed in another chapter. Spontaneous abortion. Determining the exact incidence of spontaneous abortion is difficult because many unrecognized losses occur early in pregnancy. The incidence of spontaneous abortion increases with paternal age. The incidence is 12% for women younger than 20 years, rising to 20% for women older than 40 years. So it's kind of understood that around age 35, when it comes to pregnancy, you're considered a elderly person, or a geriatric pregnancy is what some people will say, because after 35 your eggs are considered old. Most spontaneous abortions occur in the first 12 weeks of pregnancy. The rates declines rapidly thereafter. Fetal death occurs before signs and symptoms appear. The most common cause of spontaneous abortion is severe congenital anomalies that are often incompatible with life. Some of them are related to chromosomal abnormalities, usually within the first trimester. Additional causes include maternal infections and endocrine disorders such as hypothyroidism or insulin-dependent diabetes. Women who have had repeated early pregnancy losses appear to have immunologic factors that play a role in their higher than expected spontaneous abortions. Anatomic defects of the uterus or cervix also can contribute. Spontaneous abortion is divided into 6 subgroups: threatened, inevitable, incomplete, complete, missed, and recurrent. And so these are listed here for you, and I want you to read through these yourself. Again, I'm trying not to make this as too lengthy. Okay, so you have threatened abortion, you have inevitable abortion. So threatened, first sign of threatened is vaginal bleeding. You may have some spotting. And then inevitable is going to occur. It can't be stopped. Incomplete is when some of it, the conception is expelled and some of it's retained, and you may have to have a D&E, or a dilation and evacuation, or what you might hear called a D&C, dilation and curettage, where they go in and scrape out the inside of your womb and clean out what was left behind. Missed abortion or complete abortions, and it also talks about fetal maceration. Make sure that you read that under missed abortion. And then it talks about DIC, and this is really important because this is a severe bleeding disorder that is very life-threatening during pregnancy. It's called disseminated intravascular coagulation or consumptive coagulopathy, or DIC. It's a defect in coagulation that may occur if the fetus is retained for a low, prolonged period. Although DIC may occur with other pregnancy complications such as abruptio placentae or hypertension, the coagulation defects may occur in the absence of pregnancy. With DIC, anticoagulation and proagulation factors are activated simultaneously. So in other words, your bleeding factors are affected. DIC develops when the clotting factor thromboplastin is released into the maternal bloodstream as a result of placental bleeding and consequent clot formation. The circulating thromboplastin may activate widespread clotting in small vessels throughout the body. This process consumes or uses up other clotting factors such as fibrinogen and platelets. The condition is further complicated by activation of fibrinolytic system to lyse or destroy the clots. The result is a simultaneous decrease in clotting factors and increase in circulating anticoagulants, which leaves the circulating blood unable to clot. So in other words, you're bleeding from the placenta, the body thinks it needs to stop, and these factors kick in to cause these clots, but then you exhaust all your resources, and the event is you use up all your clotting factors, and then you're unable to stop the bleeding, period. The result is a simultaneous decrease in clotting factors and increase in circulating anticoagulants, which leaves the circulating blood unable to clot. This situation allows bleeding to occur from any area, IVs, incisions, gums, nose, and other sites like the placenta during the postpartum period. In DIC, fibrinogen and platelets are usually decreased. Prothrombin and partial thromboplastin, your PT and PTT, may be prolonged, and fibrin degradation products, the most sensitive measurements, are increased. The D-dimer, which is a lab test, the D-dimer which is normally negative, is specific measurement for fibrin degradation activity. So when you suspect clots, they'll do the lab test called a D-dimer. The priority in treating DIC is delivery of the fetus and placenta to stop the production of thromboplastin, which is fueling the process. Blood replacement products such as whole blood, packed red blood cells, and cryoprecipitate are administered to maintain circulating volume and to transport oxygen to the affected body cells. And then it goes into the next recurrent spontaneous abortion or habitual abortions. Make sure that you read that as well. Also on page 531, you have a term, and I do want you to know what this term is. Recurrent spontaneous abortions may be caused by cervical incompetence, an anatomic defect that results in painless dilation of the cervix in the second trimester. The cervix can be sutured to keep it from opening, which is a cerclage. Sutures are removed near term if vaginal delivery is expected, or they are left in place if the patient's going to have a C-section. So some of the issues and nursing considerations that you want to think about with some of these bleeding disorders, I'm sorry, not bleeding disorders, but different types of bleeding with the types of abortions. Like spontaneous abortion may be accompanied by various amounts of bleeding. Prevention or identification and treatment of hypovolemic shock, rapid pulse, lightheadedness, syncope, falling blood pressure are the nursing priority when a woman is bleeding heavily. The nurse should observe for tachycardia, often the earliest sign of hypovolemia. Falling blood pressure is a late sign. Pale skin and mucous membranes, confusion, restless and cool and clammy skin. The nurse manages fluid and blood replacement as ordered. So make sure that you read nursing considerations about hypovolemic shock. Then the next part, it talks about ectopic pregnancy. And this is where the ovum is fertilized and it's not in the uterus. It's usually in the fallopian tubes. And so you have a picture on page 532, and it talks about the ectopic pregnancy. And so the incidence is increasing as a result of pelvic inflammation. A lot of women, have pelvic inflammation because of infections and different types of things. So some of the symptoms that you may see in an ectopic pregnancy is a missed menstrual period, abdominal pelvic pain, vaginal spotty or light bleeding, may have positive urine pregnancy test, but you'll have a lot of pain in that fallopian tube area. And as the ovum grows, if it's not taken care of, the fallopian tube will rupture and damage your fallopian tube. They will do a pregnancy test and they'll look at that HCG levels, and they may do a laparoscopic examination. Box 25.1 is risk factors for ectopic pregnancy. Make sure you read over that. And then what is the therapeutic management? The management of tubal pregnancy depends on whether the tube is intact or ruptured. Medical management may allow preservation of the tube, thus improving the chance of future fertility or future pregnancies. Medical management is most successful if the tube is intact. The pregnancy is early, the size of the pregnancy is less than 3.5 centimeters, and the fetus is not living. And a lot of times they're not living because they're implanted in the fallopian tube, and they got to be in the uterus where that placenta can start to grow. The cytotoxic drug methotrexate inhibits cell division in the embryo. A single dose of methotrexate has shown a higher failure rate, and two-dose or fixed multi-dose therapy is more often used. So they may need more than one dose of the methotrexate. Some surgical management, they may have to do a linear salpingostomy to salvage the tube, and they may have to do a salpingectomy, whereas the fallopian tube, they're going to remove the affected tube and try to save what they can. Nursing considerations focus on preventing or identifying hypovolemic shock, controlling pain, and psychological support of the woman. If methotrexate is used, the side effects can be nausea and vomiting, and you want to discuss this and educate the patient about that. Some drugs affect or worsening symptoms suggest rupture, pelvic, shoulder, or neck pain, dizziness or faintness, and increased vaginal bleeding. The woman must be instructed to refrain from drinking alcohol or ingesting vitamins that contain folic acid, which would reduce the drug's effectiveness. She should not have sexual intercourse until the HCG levels are undetectable. The importance of keeping follow-up appointments should be emphasized. And so, these are some of the management pieces that you will deal with the ectopic pregnancy, and you'll have to teach them. Okay. It lists some risk factors here, and again, these are on page 532, and they're listed in the reading for you. Okay. And then here's some other risk factors: intrauterine device, multiple induced abortions, maternal age greater than 35. So you may make sure you read over that, but there are some things that make women more at risk for ectopic pregnancies than others, and it may be an issue with the fallopian tube. It just may not be open enough as well. The next section, beyond ectopic pregnancy, is gestational trophoblastic disease or hydiform mole. These gestational trophoblastic diseases are a spectrum of diseases that include benign hydiform mole and gestational trophoblastic tumor such as invasive moles or choriocarcinoma. Hydidiform mole or molar pregnancy occurs when the trophoblast, peripheral cells that attach the fertilized ovum to the uterine wall, develop abnormally. As a result of the abnormal growth, the placenta, but not the fetus, develops. Hydidiform mole is characterized by proliferation and edema of the chorionic villi. The fluid-filled villi form grate-like vesicles that can grow large enough to fill the uterus the size of an advanced pregnancy if not diagnosed and treated, but it's not a pregnancy. It's just this malformation of these cells. The mole may be complete when no fetus present or partial in which fetal tissue or membranes are pregnant. Malignant change and proliferation of residual trophoblastic tissue is a life-threatening complication. Acute respiratory distress may occur if vesicles of the hydidiform mole enter the woman's circulation and embolize the lungs. So what do you see with the manifestations? Most molar pregnancies are diagnosed early by ultrasound. It reveals the vesicles and no fetal gestational sac. And there's a picture of one on page 534. It looks like a sack of grapes. The level of HCG are high because of the rapidly proliferating abnormal villi. Other signs, symptoms of a complete molar pregnancy vary. Vaginal bleeding, usually dark brown spotting to profuse hemorrhage, a uterus larger than expected for duration of pregnancy, excessive nausea and vomiting, possibly related to the high HCG, and early development before 24 weeks of preeclampsia, because you don't usually see preeclampsia too early in the pregnancy. Ultrasound is used to diagnose, and then what is the therapeutic management? And usually it's evacuation with vacuum aspiration. After tissue has been removed, IV oxytocin or pitocin is used to contract the uterus. Cytotec may also be used for uterine contractions. It is important to avoid uterine stimulation with these medications before evacuation. Uterine contractions can cause trophoblastic tissue to be drawn into the venous circulation, resulting in embolization of the vesicles. Curettage with a sharp curette follows the evacuation to remove all remaining tissue, and the tissue obtained is sent for laboratory diagnostics. And so, again, this has got to be removed because it's not a normal pregnancy. And sometimes with these hydidiform moles, they actually find like teeth and hair and skin, and they'll find little body parts of a fetus that tried to form. It can be quite a psychological event when you see stuff like that. I've never seen a real one, but I have seen pictures. Hemorrhagic conditions, again, there's another issue. So far we've talked about ectopic pregnancies, or we've talked about abortions. We've talked about ectopic pregnancies, and we've talked about the hydidiform mole or gestational trophoblastic disease. And so now we're moving on to placenta previa. And so what happens with this is an implantation of the placenta in the lower uterus near the fetal presenting part. Use of both abdominal and transvaginal ultrasound allows measurement of the distance between the internal cervical os and the lower border of the placenta. Marginal, called low-lying, partial, low border of the placenta is within 3 centimeters of the internal cervical os, but doesn't completely cover it, or total. The placenta completely covers the internal os. And the internal os, if you look on page 534, is that opening where that hydidiform mole is coming out. It's the os is right in there. It's where the opening is. Marginal placenta previa is common in early ultrasound exams and often appears to move upward and away from the internal cervical os. The growing placenta does not move, however, it is drawn upward as the myometrium beneath it develops with pregnancy progression. And so with placenta previa, what you will see is sudden onset of painless uterine bleeding in the lower half of pregnancy. Bleeding occurs when the placenta villi are torn from the uterine wall, resulting in hemorrhage, and blood can get behind that placenta and cause clotting, which can lead to that DIC we talked about. Bleeding may be scanty or profuse, and it may be spontaneous. Bleeding may not occur until labor starts, when cervical changes disrupt placenta attachment. The patient may have a heavy bloody show, is a sign of placenta previa. So a heavy bloody show can be that. On page 536, it gives you pictures of presentations of the placenta. You have marginal, you have partial. So marginal and partial are very close, but then you have the total, and you see the vaginal opening or the cervical os. That's where the cervix is completely covered. Therapeutic management. How do they take care of this? The woman is evaluated carefully to determine the amount of hemorrhage, and electronic fetal monitoring is initiated to determine whether the patterns are reassuring. And we talked about those stress tests and contraction tests and non-stress tests. Nursing consideration, the woman is clinically stable. The woman can maintain bed rest at home as long as she doesn't have any active bleeding. Home is within a reasonable distance from the hospital, and the woman has transport 24 hours a day. And so some of the assessments that you look at under nursing considerations: cramping, regular or sporadic contractions, bleeding, fetal activity. So when you go out and check the patient, or when they come into the clinic, you're always going to listen to the fetal heart rate and look for bleeding, ask about pain. Okay, the next one is abruptio placentae, and this is separation of a normally implanted placenta before the fetus is born. And this is dangerous because the placenta is what feeds the infant. That's the blood connection to the infant and to the mother, that internal circulation. So when that is hindered, then circulation is cut off to the child. So when this occurs, when there is bleeding and formation of a hematoma on the maternal side of the placenta, like I said a while ago, you can get blood clots behind the placenta when it detaches from the uterine wall. As the clot expands, further separation occurs. So when you have abruptio placentae, it occurs when there is bleeding and a formation of a hematoma on the maternal side, and the clot just gets bigger, and it causes more separation of the placenta from the from the uterine wall, which is cutting off the maternal circulation to the fetus. Bleeding may be visible or concealed, and it's usually accompanied by pain, uterine tenderness, or uterine hyperactivity. Some of the signs and symptoms: you may see an increase in fundal height. The infant may be higher up. The fundal height will be measuring higher. A hard board-like abdomen, high uterine baseline tone on electronic monitoring, persistent abdominal pain, of course tachycardia because you got some bleeding, the blood pressure falls and the client's restless, persistent late decelerations in fetal heart rate because they're responding to the lack of oxygenation in the blood. Vaginal bleeding can be slight or absent. So you have 5 classic signs of abruptio placentae. These are on page 537. Vaginal bleeding, abdominal and low back pain, aching or dull, uterine irritability with frequent low intensity contractions, high uterine resting tone, uterine tenderness that may be localized to the site of the abruption, back pain, non-reassuring fetal heart rate, signs of hypovolemic shock, and fetal death. The woman may feel pain if an epidural analgesic is in place. And you have some pictures on page 537 that talk about the different types of abruptio placentae. And so the first one is marginal, so you got some bleeding. Then you have partial, you got a blood clot. This has got concealed bleeding, marginals with external bleeding, and complete abruption is with concealed bleeding, but it's completely bleeding. It's not just a clot, it's active bleeding behind there. Signs and symptoms of impending hypovolemic shock. Again, falling blood pressure, increased respiratory rate, increased pulse rate, weak, diminished, or thready peripheral pulses, cool, moist skin, decreased urinary output, less than 30 milliliters per hour, decreased hemoglobin at hematocrit, of course, because you're losing blood, and changes in mental status. And so make sure that you read through the therapeutic management. And sometimes, you know, they'll put the mother on bed rest, and then sometimes they have to deliver the fetus to make sure that the mother is not going to bleed to death. You have signs and symptoms suggesting concealed hemorrhage and the Berkshire Placentae safety alert box. And then you have a next-gen choose all that apply question, so I would try to answer that. Also on page 539, you have a nursing care plan in the purple. Please read through that because it talks about the amount and nature of bleeding, the pain, the maternal vital signs, the condition of the fetus. Remember, you're not just looking at mom, but you're having to take care of the fetus as well. You may have fetal tachycardia, maternal tachycardia, increased respiratory rate, all the things that I've already said. Collaborating with the physician for fluid replacement. We got to get an IV line going. You may want to start some normal saline. That's usually what the MD is going to order, and or lactated ringers. And you usually see normal saline or lactated ringers used in these situations. And again, like I said, they will try to stop it, but sometimes they have to deliver the fetus if the abruption is too much. It's expected conservative management in an inpatient setting can be initiated if the abruption is mild and the fetus is less than 34 weeks, shows no signs of distress, and if bleeding is minimal. Measures include bed rest, administration of a tocolytic medication to decrease uterine contractions. You have a serial Klahalyer Betke or KB test to determine whether fetal bleeding is worsening. For the Rh negative woman, RhoGAM is ordered to prevent maternal Rh sensitization, because if the fetus is Rh positive and you're Rh negative, you're going to have issues. The woman is observed for 24 hours. You want to see if this was caused from an accident or something else, and you want to look for signs of fetal compromise as well. You're going to start a large gauge IV line for a replacement of fluid and blood. Okay, the next complication in pregnancy is hyperemesis gravidarum, and this is persistent, uncontrollable vomiting. It begins in the first few weeks of pregnancy, and it's usually because the HCG and your progesterone levels are high, and you want them up. That's what helps maintain the pregnancy. So if you have it, you have uncontrollable vomiting that begins in the first few weeks and may continue throughout pregnancy. Hyperemesis is associated with loss of 5% or more pre-pregnancy weight, dehydration, acidosis from starvation, elevated blood and urine ketones, alkalosis from loss of hydrochloric acid in the gastric fluids from throwing up, and hypokalemia. Of course, you're throwing up and you're losing fluids. Short-term hepatic dysfunction with elevated liver enzymes, deficiency of vitamin K may cause coagulation disorders, and deficiency of thiamine can cause encephalopathy. The cause is not known. This condition is more common among unmarried white women during first pregnancy. Possible causes include allergy to fetal proteins, elevated levels of pregnancy-related hormones such as estrogen and your beta HCG, and also your progesterone levels. Persistent hyperemesis gravidarum may result in low pregnancy weight in a newborn with low birth weight. More recently, in association with the organism H. pylori that causes peptic ulcer disease has been associated with this condition as well. So our management, we want to focus on controlling this nausea and vomiting. Before we move on to page 541, you have a great nursing care plan on page 540, antepartum bleeding, and it gives you a little scenario. If we have time, we may cover this, go through this in class because it's really good. Okay, back to therapeutic management. The physician will exclude other causes for persistent nausea and vomiting, such as cholecystitis or peptic ulcer disease, before diagnosing and treating hyperemesis. Laboratory studies include determining the hemoglobin hematocrit, which may be elevated as a result of dehydration. Electrolyte studies may reveal low sodium, potassium, and chloride. Elevated creatinine levels indicate renal dysfunction. Treatment often occurs in the home, where the woman attempts to control the nausea by methods used for morning sickness. And this is further in chapter 13. Vitamin B6 and vitamin B6 plus have consistent evidence of benefits. Ginger, antiemetics such as fenugreek, which I don't really use fenugreek as much anymore. And this is a new book, but they really use more Zofran than they do fenugreek, but this book referred to fenugreek. And of course, it says short-term release. Drugs that act on the central nervous system, such as Zofran and Reglan, and then the steroid methylprednisone. If methods to relieve nausea and vomiting are unsuccessful and weight loss or electrolyte imbalance persists, IV fluid and electrolyte replacement, or TPN, may be necessary, and in enteral nutrition with a feeding tube. And I know people that's happened to during their pregnancy. Make sure that you read that whole section there, okay? And then your next problem is hypertension during pregnancy or pregnancy-induced hypertension. You have a box on page 541. It talks about the classifications of hypertension in pregnancy. You have gestational hypertension, replaces the term pregnancy-induced hypertension. So it's now called gestational hypertension because it's coming from the pregnancy. You have some comments here that talk about gestational hypertension. The blood pressure is 140/90 or greater and develops after 20 weeks of pregnancy, but returns to normal within 6 weeks postpartum. The protein urea negative or trace on random urine dipstick is not present. Then you have preeclampsia. Systolic greater equal to or greater than 140, diastolic equal to greater than 90, and develops after 20 weeks of pregnancy and is accompanied by protein urea equal to or greater than 0.3 grams in a 24-hour urine collection or a random urine dipstick. Eclampsia is progression of preeclampsia to generalized seizures that cannot be attributed to other causes. Then you have chronic hypertension and preeclampsia superimposed. Please make sure you read those, okay? Read that box, okay? So gestational hypertension, again, it is elevation after 20 weeks. It's not accompanied by protein urea, may progress to preeclampsia. If it persists more than 6 weeks after birth, then chronic hypertension is diagnosed. Risk factors for pregnancy-related hypertension or gestational hypertension, as it says: first pregnancy for mother and father, men who have fathered one preeclamptic pregnancy, age greater than 35 years, anemia, and a family history of preeclampsia. And if you already have a history of hypertension when you got pregnant, that may be a factor as well. Other risk factors: chronic hypertension, renal disease, obesity, diabetes, and having more than one fetus in the pregnancy. So multiple, like twins or triplets. Pregnancy from assisted reproduction techniques. So, you know, artificial insemination. Preeclampsia And so all of these, preeclampsia, all of this falls under hypertension, and then it goes into eclampsia, which is where you start having the seizures. And on page 549, you have a preeclampsia care plan, and I want you to read over that care plan, okay? It's very important. So preeclampsia, you have generalized vasospasms, decreases circulation to all organs of the body, including the placenta. So if the circulation is decreased, then I'm cutting off blood supply to my organs and to the fetus. So what are some of the manifestations that you see? Look on page 543. The first indication of preeclampsia is hypertension. And then you will start to have blood pressures running 140/90 or higher. Protein in the urine can be identified. Other symptoms, you have deep tendon reflexes, may be very brisk or hyperreflexive, suggesting cerebral irritability. Upper extremity reflexes should be assessed if the woman has epidural. Other signs and symptoms, look further down on page 543. It can develop and progress rapidly. The early symptoms often go unnoticed. Certain symptoms such as headache, drowsiness, mental confusion indicate poor cerebral perfusion. Visual disturbances and blurred vision, double vision, that's always a sign as well. Epigastric pain or upset stomach. And these are typical in pregnancy. You also have generalized edema, and it can be pitting. You have edema in the face and the lower extremities. You have some pictures on page 543 to look at for that. Home care, you want to activity restriction, monitoring of fetal activity. Of course, monitor the blood pressure. If it gets worse, they need to go back to the hospital. If they continue to gain weight because they're still retaining fluid, if the protein that they're spilling is higher, they need a diet without salt, and you need to do fetal assessments. And all of that's listed there on page 544 for you. You have a table, mild preeclampsia versus severe, and so it gives you the different readings. So mild is systolic 140 to 160 and diastolic 90 to 110, but severe is greater than 160 and greater than 110. The protein in mild is 0.3 grams, and it's greater than 5 in severe. And then you have urine output may be normal, or you may have less than 500 milliliters a day. Visual disturbance, sparkles in your eyes, pulmonary edema, heart failure, cyanosis, fetal growth restriction. Your liver enzymes may be out of whack, your platelets as you get severe. So you can see the difference from mild to severe. Needs to be treated in the mild because once it gets to severe, it's hard to treat, okay? And here's an assessment of edema that you can determine if it's 1+ or 4+. Look on page 545 before we get into eclampsia and talking about anticonvulsant medications. So if the patient does progress to eclampsia, you want to have this mag sulfate available, because with the eclampsia, you're going to have the seizure. So mag sulfate is the drug most commonly used in the management of preeclampsia. Magnesium acts as a central nervous system depressant by blocking neuromuscular transmission and decreasing the amount of acetylcholine liberated. Magnesium is not an antihypertensive medication, but it relaxes smooth muscle, including the uterus, and thus reduces vasoconstriction, possibly resulting in modest blood pressure reduction. Decreased vasoconstriction promotes circulation to maternal vital organs and increases placental circulation. Increased circulation to the maternal kidneys improves diuresis, and intestinal fluid is shifted into the vascular compartment. Although mag sulfate is not risk-free, it has the major advantage of a long safety record for mother and baby. Fetal magnesium levels are nearly identical to the mother. As a result, the fetal monitor tracing may show decreased fetal heart rate variability. No cumulative effect occurs, however, because the fetal kidneys excrete magnesium effectively. The therapeutic serum level for magnesium is 4 to 8 milligrams per deciliter, or as set by the healthcare facility. Adverse reactions to mag sulfate usually occur if the serum level becomes too high. The most important is central nervous system depression, including depression of the respiratory center. MAG is excreted solely by the kidneys, and the reduced urine output that often occurs in preeclampsia allows MAG to accumulate to toxic levels. Frequent assessment of serum levels, so deep tendon reflexes, respiratory rate, and oxygen saturation can identify central nervous system depression before it progresses to respiratory depression or cardiac dysfunction. Monitoring urine output identifies oliguria that could allow magnesium to accumulate and reach excessive serum levels. So monitoring urine output while you're on mag sulfate is imperative. Look at your drug guide, and it gives you all the information about mag sulfate, and it's given IV, and you follow a protocol. The loading dose is 4 to 6 grams, and it's administered at 100 milliliters of fluid over 15 to 20 minutes. The continuing infusion to maintain control is commonly 2 grams per hour. Deep IM injection is acceptable, but it is very painful. You want to monitor kidney function. You want to monitor heart rate. You want to monitor those deep tendon reflexes. Magnesium toxicity, possibly related to incomplete renal drug excretion, may be evidenced by thirst, mental confusion, or decreased reflexes. So do the DTRs, deep tendon reflexes. Adverse reactions result from MAG overdosing, including flushing, swelling, hypotension, depressed DTRs, or deep tendon reflexes, and central nervous system depression, including respiratory depression. Monitor blood pressure closely during administration. Assess woman for respiratory rate at least 12 breaths per minute. Oxygen sat of 95 or higher. Presence of deep tendon reflexes and urinary output greater than 30 milliliters. Place resuscitation equipment, suction oxygen in the room. Keep calcium gluconate, which acts as an antidote to magnesium, in the room along with syringes. And we learned that in the chapter that we went over about electrolytes. And that was in your reading for magnesium. That is, the antidote is calcium gluconate. And we talked about that. It's usually administered by IV infusion, which allows for immediate onset of action and does not cause the discomfort associated with IM administration. IV magnesium is administered via secondary piggyback line so that medication be discontinued anytime while the primary line remains functional. And then it talks about the antihypertensive medications that they may need to give, hydralazine, and it's one of the ones of choice, but you still have to monitor. You need to monitor for seizures, and you have to monitor continuously for seizures and changes to the circulation in the placenta, so the baby's going to be hooked up to a monitor. And also, you may be on IV Pitocin if you're trying to induce labor. So again, the baby's going to be on a monitor. Look on page 546, assessing deep tendon reflexes. You need to read over this. You guys should have had this in health assessment. If not, you need to read over this again. I'm already about 45 minutes into this recording, so I don't want to make it any longer, but make sure that you read it yourself, okay? So again, preeclampsia can turn into eclampsia, which is where you have the seizures. And on page 547, it talks about nursing assessments for preeclampsia and MAG toxicity. And then it talks about the therapeutic management of eclampsia, and that's what we were just talking about, using the mag sulfate and monitoring the urinary output, the patient's if any seizure activity, their change in mental status, their respiratory status, their blood pressure, and the fetus is on the monitor looking for changes in heart rate, decelerations, and we talked about that earlier in another chapter. Interventions for seizures, again, initiate preventative measures, monitor for signs of impending seizure, headache, a patient says, I feel funny, their eyes will change, protect the woman during the seizure, but remember, we don't hold patients down, you just want to keep them safe, and monitor for signs of magnesium toxicity. All right, the next thing is the HELP syndrome. And what in the world are we talking about when we talk about HELP? It is an acronym. HELP describes a life-threatening occurrence that complicates approximately 10% of pregnancies in women with severe hypertension. As in preeclampsia, HELP syndrome can occur during the postpartum period. Hemolysis is believed to occur as a result of the fragmentation and distortion of erythrocytes during passage through small, damaged blood vessels. Liver enzyme levels increase when hepatic blood flow is obstructed by fibrin deposits. Hyperbilirubinemia and jaundice can occur as a result of liver impairment. Low platelet levels are caused by vascular damage resulting from vasospasms. Platelets aggregate at sites of damage, resulting in systemic thrombocytopenia. The prominent symptom of HELP syndrome is pain in the right upper quadrant, the lower chest, or the epigastric area. There may be tenderness because of liver distension. Additional signs and symptoms are nausea, vomiting, and severe edema. It is important to avoid traumatizing the liver by abdominal palpation and to use care in transporting the woman. A sudden increase in intra-abdominal pressure, including a seizure, could lead to rupture of a subcapsular hematoma, resulting in internal bleeding and hypovolemic shock. Women with HELP syndrome should be managed in a setting with full intensive care facilities. Their treatment includes that which is appropriate for preeclampsia or eclampsia. After delivery, most women begin recovering within 72 hours. So on your slide, look at HELP. Hemolysis, elevated liver enzymes, and low platelet syndrome. So hemolysis occurs as a result of the fragmentation and distortion of erythrocytes, just as I said, during passage through damaged blood vessels. Liver enzyme levels increase when the hepatic blood flow is obstructed by fibrin deposits. Low platelet levels are caused by vascular damage resulting from vasospasms, so you end up with these clots and you have all this pain. It is a medical emergency, and they need to be in ICU, and they will treat them with fluids and try to stop, this bleeding issue. Chronic hypertension, we've kind of already mentioned that, so I'm going to have you read. Hey everyone, when I got to this last slide, something happened to my recording and it did not record what I talked about. But what I did was I picked up on page 5, let me find it, on page 551, where it starts about incompatibility between maternal and fetal blood, and I pretty much read that whole section there to you. Evidently it did not pick that up, and I'm not going to re-record that because it took me quite a while to do that. So when you're listening to this recording, when you get to 551, and we will discuss this in class too, make sure that you actually read this entire section, okay? Because it's important to understand that if you're Rh negative and they assume the fetus is Rh positive, that you're going to have to get the RhoGAM, okay? Because the Rh positive has the antigen factor on it. So when you start on page 551 and read to 553, it explains it very well. I don't even think it picked up where I went over the box on page 552. Parents want to know about Rh incompatibility. Please read that box and read the box about the RhoGAM medication. And I'm sorry it didn't pick it up. I read every word and explained it to you. So we will talk about it in class as well. I will have to go back and reread it. But basically what's happening here is if you are pregnant and you say, like I said, my blood is O negative, my daughter was A positive, my husband was A positive, and usually the father is the one that contributes the positive antigen factor. Though the antigen on the Rh blood, if it's maternal blood and fetal blood is not supposed to mix, but it can if there's issues with the placenta or issues during delivery or any complications. So when these positive antigens get in the blood, the body sees it as foreign and it'll attack it and cut off the blood supply to the fetus, and the fetus could die. It is a very serious situation. On page 551, it shows you figures of how just 1 or 2 drops of blood can affect the fetus that's assumed to be Rh positive. So you get it, the RhoGAM before, so this doesn't happen. It's how you get the shot at 28 weeks. And then if you're a O negative blood type and your fetus is a positive blood type, you will get the RhoGAM again within 72 hours. And again, I apologize it didn't pick it up. We will discuss this in depth when we get to this part. But again, please read page 551 through 553. You need to read all of that, okay? You need to read every bit of it. All right, thank you.